inside, or when we decide to remove it, what is the justification of that? And in the last, we'll talk about multiple extraction, treatment planning, and okay, indications to do open extraction or surgical extraction. If we have dense bone, especially for the buccal cortical plate, if it is very dense, also in older patient, because in older patient there will be more calcified bone, and also if the patient have habit of bruxism, and we'll see all this in details. Okay. Also hypercementosis and apparent root morphology, dilaceration or divergent root. Also, if the tooth is approximated to maxillary sinus in the upper attrition and short clinical crown. Okay, so crown to short clinical crown attrition, they will lead to dense bone or thick periodontal attachment. So they will be more resistant for bone expansion forceps. So it's better to do open extraction or open technique. In hypercementosis, they will be continuous cementum deposition or accumulation in the root area, as you can see here in this premolar, second premolar, see the root area. So root shape is bulbous root, so will be more resistant, and if you remove it by simple extraction or decide to remove it by simple extraction, it can lead to fracture. So there will be retained root inside. So it is removed through the socket, especially in this area. The root is larger than the opening here. So this will lead to fracture of the root. So it's better to remove it by surgical technique, not simple technique. Also, if we have divergent roots, that is why we are taking X-ray before or pre-operative X-ray. Look for this root. It is diverged from each other, so it will be very difficult, and they will be more resistant for forceps movement, and this can lead to either bone fracture, buccal bone fracture, or root fracture. Also, in lacerated root, see here, so they will be resistant during movement. So the result, it will be fracture of the root inside. So in these cases, it is better to do it by surgical technique. If we have root close to maxillary sinus or the root inside the maxillary sinus, so if we remove it by simple extraction, so the result may be sinus perforation or oro-antral communication. We call it oro-antral communication, or maybe displacement of root or tooth inside the maxillary sinus. So it is better in this case to remove it surgically. In restoration, as in bruxism, also it will be weak crown. If you grasp this can lead to fracture of this part. So it will result in retained growth inside, but it's better to remove it by surgical extraction. Also, same thing in the badly decayed or extensive caries tooth or teeth. So, open extraction technique. If we have single rooted tooth, okay, step one, first we should do after anesthesia, mucoperiosteal flap line, envelope or three corner. Okay, it is full thickness flap, one cut till the bone. Okay, after that we'll get accessibility to the area, and so this will help in accessibility and visibility. It should be wide flap with the base is larger than the margin, because if the base is larger, this will lead to good blood supply and the healing will be under. So after flap or mucoperiosteal flap reflection, we can, if we have access to the tooth, we can reset the forceps after reflection of the flap. We can reset the forceps apically, more apically, and then we can remove it by forceps. Or sometimes we can remove slight buccal bone by using forceps, and then apply more apical force grip, and then we can remove it by buccal force. Option 3, we can use straight elevator from the palatal side, that direction. Okay, so the tooth will move to least resistant area, which is buccal area. So we'll apply this straight elevator in the palatal side. Or if we have thick buccal bone, then we can remove slight buccal bone. It is either 2/3 or at least half of the root length from the buccal side by using straight Hambis and surgical burr. Okay. After that, we can also apply either forceps or elevator. Is it clear? If you have question here, please ask. If the buccal bone is thick, then we can remove buccal bone 2/3 or half. Yeah, very good, very good. After that, we can apply either forceps or elevator from the palatal area. Those will move toward the least resistant area, which is buccal bone. As you can see here, applying the straight elevator from the palatal side, so the tooth will move toward the area. Also, removal of solid root in the bone, we can use or apply Purchase point here. After buccal bone removal, still the tooth is retained inside. Okay, so apply Purchase point in the push it by this elevator from down up to down, and after that we'll close the flap. So elevator in Purchase point. This will help to move of solid inside the bone. Okay. If we did that all for single rooted tooth, if we have multi-rooted tooth, so that means molars, either lower molar or upper molar. Let's see first the lower molar. The first step after anesthesia is reflecting or applying the flap. Okay, first thing. Then crystal bone removed for bifurcation exposure. So we remove buccal bone till the forcia is appeared. Then we'll apply or we'll section the tooth into parts, either sectioning into for medial and distal. So then after that we'll remove each part as single root, as separated tooth. Okay, is it clear? Okay. See here, first reflection of the flap. Okay, after that sectioning here, removal of crystal bone till exposure of forcation area. After that, sectioning of the root into two parts, okay, from the forcation area. After that, removal of mesial one and then distal one, and after that, closing of the flap or the wound. Okay. Alternative method for that: first apply flap, then crystal bone removal till exposure of forcation area. Then we'll cut only crown with one root, either crown with mesial root or distal root. Okay. The distal root here will be separated from mesial root and crown, and after that we'll remove crown with one root, and then we'll apply cryer elevator by wheel and axle principle to retrieve the distal root. Either we can remove distal or mesial root. Okay, one root with the crown and the other root will retrieve by cryer elevator. Okay, it clear? And after that, we'll close the wound and do socket management. Okay, thank you. Okay, good. If we have mandibular molar with loss of crown or without crown, we'll apply first after anesthesia flap. Okay, then crystal bone removal and sectioning of the roots. Also, we can create precious bone in one root. Okay, so after that, root will remove separately by cryer elevator, mesial root and then distal root. Yeah, flap, then exposure of crystal area, then separation of the root, then creation of precious point in one root. After that, removal of one root by cryer elevator and use the other cryer elevator to retrieve the other root. Okay, let's go to the upper molar, intact maxillary molar with crown. So as you know, the upper root, the upper tooth or upper molars has 3 roots, 2 buccal and 1 palatal. So first step after anesthesia, reflection of the flap and crystal bone removal from buccal side to expose bifurcation area for buccal roots. Okay, then buccal roots is divided, crown with palatal root is removed alone, and after that we remove the 2 palatal root. Okay, first sectioning of the 2 buccal roots from the crown, so the crown will attach to the palatal root. Use forceps to remove crown is palatal root, and after that we remove the palatal 2 buccal roots separately. After that we'll close the wound. So in this case, you can ask why we remove. We have crown. So again, we'll go to the indication. It can be either close to maxillary sinus or it can be divergent root from each other. So this is the indication for surgical extraction. Okay, any question? You can ask. If you have any question, you can ask. Because this lecture is short, I want all the steps to be very clear to you. Yes, sure, the bone will heal later. Okay, because we'll restore the or will cover it by the flap. Okay, as I said, flap should be designed very well to have a good blood supply. This is will heal the bone, inshallah. Okay, yes. Okay, if we have maxillary molar without crown or lost crown, okay, first we'll apply flap, full thickness flap, and after flap we'll remove crystal bone from the buccal side. Then we have 3 roots. We're sectioning the 2 roots in 3 parts. We'll separate the 2 buccal roots and then we'll separate 2 buccal roots from the palatal one. After that, we'll remove the root separately, one by one. Okay, after that, we'll cover the flap or return to its original position and suturing. For suturing, we have to do socket management. If there is any sharp bone or large bone or like this, we can do bone removal and smoothing. Irrigation, and last thing is to close the flap by suture. Okay, as you can see here, separation by using handpiece, separation of 2 buccal roots and then separated from palatal one. Then use this elevator to remove the 2 buccal roots, okay, and use bayonet forceps or elevator, either bayonet or elevator to retrieve the skeletal root. If we have root fragment or tips, small tips inside, how we can remove that? Okay, either we can use this fine or sharp instrument. We should have here good accessibility and visibility, okay, to see the root and bone area. So we can put it be just between the bone and root fragment. Then by using this apixo elevator to remove it. If you can't see or you don't have good accessibility or good visibility, and just upward, so this is wrong because this is connected to displacement of the root, any facial space or vital structure like maxillary sinus or like that. Okay, this is, we call this close technique. Okay, just close technique. If you have good accessibility and visibility, if you don't have that, so then we can move to surgical or open technique by first apply or raise flap, then buccal bone removal, and after that we can apply either straight elevator or forceps from the palatal side, and we'll move the tooth against the least resistant area, which is buccal side. Okay, is it clear? Okay. Okay. Removal of root fragment by open window technique. Okay, open window technique without buccal bone removal after flap design. Okay, then we'll imagine or just locate the apical area. So we'll make a small window here in the buccal bone by using surgical bare, and then we'll use this fine instrument to push the root fragment downward through the socket. So we call this open window technique. Open window technique without buccal bone removal. Just a small window here in the very area. Then pushing the root, okay, by fine instrument or straight elevator. Okay, if we have root fragment, okay, small piece inside the socket, how we can justify it, to leave it or move it? First, we have to consider the risk and benefit of surgery. Okay, there is 3 factors to leave the root inside. If the root fragment is less than 4 millimeter, okay, and the fragment is deeply embedded inside bone, not superficial area, okay, or the bone or the periapical area or the fragment is not infected, okay, there is no radiolucency in the X-ray. So in this cases, it's better to leave it. Okay, we can leave it. Because if we want to remove these small pieces, this is need more or extensive bone removal from the jaw. Okay. Also, if it is embedded deep and close to the vital structure, so they may be harmful to the either nerve or sinus. Okay. So in this case, the justification is to leave the root inside. It will not cause any problem. Okay, by time it will resolve. Unless there is infection and the root fragment is more than 5 millimeters, okay, and it is not deeply embedded, or there is any periapical radiolucency or infection, so this may lead to pathology in the future, maybe cyst or like this. So in this case, it's better to do open the flap and buccal bone removal, and then we have to remove the root fragment. Okay, so this is great if there is extensive bone removal required, or endangers any vital structure, as I said, or risk of displacement of fragment, ideally submandibular space or lingual pouch or maxillary sinus. So it's better in this case is to leave it if there is no infection and the root fragment is less than 4 millimeter. Okay, if we have multiple extractions, treatment plan should be include rehabilitation and pre-prosthetic surgery if needed. Then we'll go to extraction sequencing. If we have upper and lower extraction, maxilla before the mandible, okay, and posterior teeth first, then anterior teeth, leave the canine, and last is canine. Okay, why maxillary teeth first? If we remove mandibular teeth first, and after that go to you go to the remove of maxillary teeth, any fragment or restoration or materials can felt down in the socket and can lead to infection. Okay, so maxillary before mandibular. So in maxillary and mandibular, first we should start by posterior teeth. Okay, if we start by anterior teeth, so they will be maybe bleeding, and then maybe the operation field will be before the posterior teeth. So this is will interrupt the accessibility and visibility. Okay, so after posterior teeth, we'll go to the anterior teeth and leave the canine, because canine is the longest root, or the longest root is the canine. So if you remove those mesial and distal to it, so it will be least resistant, and the extraction of canine will be very easy. So it's better to leave canine at the end. Okay, is it clear? Is it clear? Okay, very good. Very good. So extraction technique of multiple extractions. If we have this mandibular extraction, first we'll do incision. Okay, after that reflection of flap, then we'll start to luxate. Luxate means slightly mobile or moving the tooth by either elevator, okay, sometimes by forceps. Then extraction with forceps, posterior teeth, anterior teeth, and last thing is canine. So after extraction, if we have large bone, we can trim it by Ronger bone. Okay, if we have excess soft tissue, we can cut it. Okay, and then apply suture. Okay, and suture should be removed after 1 week. So this is the step of multiple extraction: incision, then luxation of the tooth, then removal of posterior teeth, anterior teeth, and canine. After that, if you have large bone, we can trim it by Ronger. Then, if we have excess soft tissue, we can cut it. Then close the wound, suturing, and after 1 week, we should remove the suture. Okay. If you have any question, please ask. If you don't have, please write your name and you can leave. I think this is we reach the end of the lecture. I hope it is clear to you, this technique, or this technique